Informed that you have a PowerPoint presentation.
That's correct.
All right, thank you. You can take us through then your presentation.
Thank you very much for the opportunity. So the Faculty of Consulting Physicians of South Africa represent the consulting disciplines, and we're a subgroup of the South African Private Practitioners Forum, who represent multiple societies. And we have logistical support from a group called Healthman, who do all the logistical support of all our societies. So I'll be speaking mainly on behalf of the Physicians Association, and specifically just excluding the cardiologists because they are a separate group from us. So we include from general physicians, pulmonologists, endocrinologists, rheumatologists, gastroenterologists, neurologists, and intensivists, and I think I've remembered all the ologists, and nephrologists as well, so except cardiology. So we represent the, especially specifically private practice members, but we also have some public sector doctors part of our society. So there are three main definitions that we need to look at. First of all, fraud, where there's a willful misrepresentation of what is actually given to the medical scheme. I don't know, can you see the slides?
Someone should have put them here on our screens, but apparently no one has done that, but carry on.
Okay. Secondly is if there's waste, where there's useless expenditure or consumption. And thirdly, where there's abuse, where there is inconsistent with sound medical and business practice. And these are the definitions applied then in when we assess what happens with our members. So I think there are a few discussion points, and I'll try to go through these, and I think we can either have questions as we go, or if anything is unclear, please just stop me and we can go through those. Oops. So coding, I think, has been a problem, and these would be particularly coding looking at our, when we see a patient and you perform a procedure, there has to be a code to describe what you've done. And with that code, you then present it to the medical aid with your invoice, and that would then say, what have you done, or how much time did it take, and so on. So there's been a problem after 2006, because the coding done through a combined discussion on codes stopped happening because of the Competition Commission investigation that thought that this was not conducive to fair practice. And from that time, it's been a problem. So many procedures that have developed over time, there are the codes that have had to be adjusted have not been accepted by some of the funders. Some funders have accepted it. There's a lot of obsolete and old definitions and descriptors. There's new technologies, new procedures that have not had adequate representation. And so for many of the funders, and it's difficult to name particular funders, so they use the reference price list of 2006 for their forensic investigations. So we're not really up to date with 2019 where we should be. There's sometimes also differences in opinion and interpretation of the codes, and so the coding is not perfect. So I think that is the starting point also from our side. The coding manual devised by South African Medical Association has always been the sort of blueprint that everybody has used. But again, some of these codes have not been accepted. And I'm not going to belabor that because I think the Healthman and SAPAF presentations would focus on those more specifically. From the physician's point of view, I will go through some of the ones that particularly affect us. And just to show you in bold, the main ones, let me just see, the main ones that are pertaining to physicians. So if you deviate from the norm, so the way the medical aids assess this, they have a profile of all the physicians in the country, We have around 624 physicians, general physicians in the country, and then the various smaller groupings, for example, neurology. I think there's 39 neurologists in private practice. Intensivists, I think there's 11. Rheumatologists, I think it's about 48 of them. Gastroenterologists have a few more, but they've recently been part of FCPSA, so we don't have that much information on their side. But all the groups...
These are in the private sector, these numbers you're referring to?
The 624 includes the public sector. So in private sector, there's about 450 general physicians. Of these, we have about 250 that are members of our society. Not everybody is a member, which is also a problem. So the way that they've evaluated this is they've taken a view of all physicians in the country, and then they would compare the individual doctor against that sort of general number, and then they say you don't fall into the norm. What we've discussed with the funders on various circumstances where, for example, if you have a doctor working in Vryburg in the Northern Cape, there is only one physician, almost in a 200-kilometer radius. So, of course, that doctor will deviate from the norm because of their geographic position. In some centers, for example, in an urban setting, there's many more physicians. So there it's much easier to actually compare the groups or the person against the doctors in that group. And we've tried to...
Dr. Cook, can I just ask a question about your example that you gave about the doctor in Vryburg who would obviously deviate from the norm? Can you tell us how that doctor would obviously deviate from the norm?
So because he's the only person in that area, they would receive all the patients from that more or less 200-kilometer radius. Some would go through to Cape Town if there's need for more intensive investigations or management that's not possible in his immediate hospital. But he would have many more admissions to hospital purely because of his position. And oftentimes, the doctors in these peripheral areas are inundated with patients because they just aren't, there's nobody else to see the patient, so they often get admitted to hospital. So if you look at admissions to hospital, they would appear to be an outlier because of their geographic location rather than that they're abusing the system. And this has been, again, a situation where we've had to try and explain those outlier situations because sometimes they didn't have the geographic location of the doctor to be able to interpret why they look like an outlier. The second point that developed is that they often don't know if the doctor specializes in a certain group. For example, they may be a 180 practice number as a general physician, but they may have an interest in cardiology, for example, or they may have more gastroenterology interest. So they may appear to be an outlier, but it's actually in keeping with their training and with their particular interest. But they're not a gastroenterologist. So the coding doesn't fit with the doctor's practice number. But their practice number as a general physician is how they then picked up as an outlier because they're being compared to other physicians. So we've tried to...
Sorry,
yeah.
Just to follow up on that. So those are reasonable explanations for why a physician would appear to be an outlier?
Yes.
In the context of an investigation, the doctor would inform the funder that, or the administrator, that
yes.
this is the reason for the number of admissions
exactly.
I'm responsible for, and then wouldn't that resolve the problem?
So what unfortunately happens that sometimes they already sanctioned without an explanation. So there's also been some situations where unfortunately the doctors have not responded to the investigation or the letter to say, look, we've picked you up as an outlier, please explain. So that has been a problem, and we've tried to ensure that our members understand you have to respond. We've asked them, please to respond through Healthman, because we have a whole group of people that help to support that kind of investigation, because we know that there would be reasonable explanations in many cases. And I'll get to some examples where there's not reasonable explanation and where the doctor was found to be guilty. So I think it's just that we've, over time, as the funders have become more robust in their investigations and they've been able with their IT systems to determine these outliers that pick up on just the practice data.
Can you just tell me this, Dr. Kok? I mean, so you're talking about someone deviating from the norm.
Yeah.
What is the norm?
So as I said, that they would take everybody in the country, pick up sort of a bell curve and say, okay, so your practice falls completely outside this bell curve. And then they would say that this is an outlier practice. But then they haven't looked at the 2 points. What is the geographic area? How many doctors are there in his area or her area? Are there any support services? So for example, if you're sitting in a peripheral area, do you have a cardiologist available to refer to? Or do you have to see everybody that comes? Do you have a neurologist? Do you even have a scan that you can do scans on patients that present with a stroke, for example? So in many of the peripheral areas, these doctors work in isolation under extreme pressure. And they may look like an outlier on paper, but they're not, because of their situation and where they actually practice.
Now, how do we know that they look at the national average? I mean, you say so they look at each and every doctor in the country. So
Yes.
how do we know that?
They do it under the physician number, the practice number 180, and they then draw up I can call it a standard, and then they compare the doctor against that. So this is particularly from Discovery Health, and I think they've had the most advanced IT evaluation of where we practice, what we do, what is our performance of all the funders. And they've given us some feedback on an annual basis since 2016 of how you as individual compare to your peers in the country. So they've really helped us to understand what the issues are, and they've given us the opportunity to then, if they do pick up an outlier, to discuss that particular doctor's situation and to understand better why they showed up as an outlier. And they've been very good with engaging with us, not in all cases, but in many cases, to understand better why that doctor would show up as an outlier.
And so you've got this national average, which if you're a doctor in Vryheid, you have no idea how it's compiled. And then you get identified as an outlier or a potential outlier. But all of this is a desktop exercise. Somebody is sitting in Sentin looking through a computer.
Yeah.
Now, from your experience, especially with the larger schemes, at what point do you as a doctor then get terminated? And the scheme says we are no longer referring patients to you and we are no longer honoring the accounts that you submit.
So what we've experienced, and this has been at the can I call it the insistence from our side, because we may only know once the doctor has received a letter that there's an issue. So it's one of our problems that I don't have a clue what the guy in Vryburg is doing. I'm in Alberton. I don't personally know the guy in Vryburg. So I am absolutely reliant on the scheme to come to me and say, look, you're the president of your association. We've picked up this pattern of behavior of this doctor. Do you agree? Don't you agree? How do we manage it? So we've implored them, please discuss with us so that we can investigate with the doctor, understand their circumstances. And then if there's a true abuse, we would discuss it with that doctor, and we could do a peer-to-peer discussion and say to them, look, we've picked up this issue, what is causing it? Is there an explanation? It's been a problem that not every physician, as I say, belongs to our association. But if there's been some circumstances, and I'll show you some examples, where they have come to us, we've been able to resolve many of the issues that have come up because there was a reasonable explanation for their supposed outlier status, according to the funder.
Yes. You see, what I'm trying to understand is, so there are two stages at which the doctor is told by the scheme that claims from you will not be honored. The first is where the scheme picks up that there is something wrong with you. You've been
Correct.
an outlier. And they say, look, we're about to start an investigation, and before we do that, we are putting you on what they call direct payment. So
Yes.
we will pay your patients directly. The other stage is where they conduct an investigation and the doctor does not cooperate.
Yes.
And they say, well, we are not going to tolerate your non-cooperation. We're going to put you on direct payment.
Yeah.
What is your experience about these two stages of termination?
So we really have mainly discovery to go on because some of the other funders, GEMS have had some investigations, but they were quite advanced by the time they involved us. And this has been the situation with Discovery, that they have really gone through several iterations of a letter advising the doctor that they've picked up that there's an outlier behavior that they have wanted to investigate. And I think many of these don't even come to our attention because it is resolved, as I understand. They would not stop payment or do direct payment unless there's been complete non-compliance from the doctor's side or absolutely no response to letters. And I do know that they personally do go and visit the doctor. So if it's a representative in the area or an area manager that would physically go to the doctor's practice to visit them. There are circumstances where the doctors refuse to see these representatives, specifically from Discovery, because I know that that has been an issue. And again, you know, in that situation, it's very difficult to help the doctor if they don't give an opportunity to evaluate what is actually happening with their practice to understand better. So that has happened in some cases, unfortunately, because I think the more you can open your books, show what you're doing, and there's transparency, obviously you can defend what you've done. So we've tried to ensure that our members understand that it's absolutely crucial. If you feel that you've done correctly, you must be able to defend it. I don't think that there should be an issue with that. So if the funders has picked up a problem, we've asked our members to please be in contact with us so we can help you through the process, understand better what the issues are, and then see where there's been a problem that occurred. For example, in some instances, especially with young doctors going into practice, they've had very bad advice on coding. And so there's been abnormal coding practices, for example, where they don't understand in intensive care what the particular code should be. They may have added codes where it wasn't appropriate, or they applied a certain code that wasn't applicable in that situation. And so many of those we've actually been able to resolve because it was a pure misunderstanding in a doctor going into practice new and not having the information at hand to know exactly how to do their billing correctly.
Yes, just want to understand something else, just also based on your own experience. So you told us earlier that what you find is that typically it's the doctors in the outlying areas. You make the example of Vryheid. I hope no one is from Vryheid here today. Vryburg. Oh, it's even worse.
Northern Cape.
But what is your experience of the class of doctors that are affected? I mean, you know that this inquiry also partly looks at racial profiling.
Yes.
Have you found that the bulk of those that are affected are white, black, mixed?
Can I go on to a further slide? Then I can show you the exact details.
Oh, okay, thank you.
Okay. And I just, the one other thing, because we are consulting physicians, the hours that you spend on the after-hours consultations, that's also caused some problems. So there's some additional codes, 0145, 4647. 47 is away from your practice after hours in emergency code. So if they pick up that every single patient that you see is an emergency code, you would also be seen to be an outlier. But in some circumstances, every patient you see is after hours. So it's a situation, I mean, even Secunda. Vryburg is an extreme example, but there's been one doctor in Secunda for years. He's now got a second person helping him. In PE, for example, there were 8 physicians, 4 have retired, so suddenly you've half the physicians. So the practice is just a practical thing that the physician are the people that really are the backbone of the hospital. And also, if you're stuck with a patient, you consult a physician. You know, you need to know where do you go with this patient. So oftentimes the physician would be your final step of asking advice, getting support, trying to understand what the situation is with a particular patient. So you would, I mean, in my hospital, for example, I've got about 48 GPs that refer to me. But I've got, in my hospital, we're 6 physicians. So there's a spread. So I won't come up as an outlier easily because there are other physicians seeing patients. But if I'm the only person in Secunda, and I've got 48 GPs referring to me, of course, the profile of my practice will be completely different. And it's taken the funder some time to understand that. I think you know what triggers the investigation, so I'll just go through this quickly. So just to show you, so this is our physician membership. So we have 250 physicians on our books, and that's the distribution also with the geographic distribution. And the fact, for example, in the Free State that you see that there's one, and can I just mention that we don't have actual racial registration at our society. Anybody comes, these have been absolutely inferred from the patient's surname. And so I apologize if that is racial profiling. It's the only way that we really had to do it. I also don't have a male-female distribution, but I can tell you that the majority are male.
What is brown?
Exactly. Yeah. I didn't draw up the slide, so I do. And other as well. That's a person who didn't want to be classified as anything. So I do apologize. That should obviously not be brown.
Well, certainly it's not white.
Yes. So, I mean, our crazy country, eh? And for example, as you can see, like KwaZulu-Natal, there'd be a focus of Indian doctors, etc. So it just to give you a bit of a spread of the doctors in the various areas. So does that answer your question, just to give you an idea? So just to, so part of our problem has been...
something further. I mean, that is your pool.
Yeah. So
but
yes,
I want to know, out of that pool, what the rate of investigations per category?
Yeah, so there they are. Just to show you the members per race category, and that gives you the percentages. So of the African doctors that are members, 35 of them, 6 were investigated, 3 were investigated, which makes up 8.6%. Of the colored doctors, there was really very few, if none. Indian doctors, there was 14.3%, and white 4.7%. So that's the total that have been investigated. Does that answer your question?
Yes, and if you add the 14 plus the 8.6%, if you classify all those as black, then you are at 21 point something percent versus only the 4.7% of white. I mean, yes, it does. Thank you.
Then in summary, just to look at the audits, so of the 22 physicians that have been approached by our group, FCPSA, Faculty of Consulting Physicians, 18 of these had to refund the medical schemes to some degree. 14 of these, there were anomalies found, and as I said, these were mainly due to abnormal coding practices where they misunderstood codes. And we don't know what the recovery amounts were because it wasn't discussed with us. But the doctors agree that there was a coding abnormality and we could account for those. In 4 audits...
If it was a coding anomaly, why would a refund be necessary?
Yeah, I don't know if there was even a refund negotiated. I just know that there were anomalies found. And when I say they had to refund the scheme, I don't actually know the detail of what happened. But can I call it there was an agreement with the doctor? So there wasn't non-payment, and there wasn't a complete, like a direct payment to the patient that we know of. In 4 situations, there was no anomalies were found. So even though the doctors were cited to be an outlier, it was never confirmed. And in 4 audits, there was a significant refund to the scheme, 2.6 million over the 6-year period that was assessed. So we try to ensure that our physicians understand why audits happen, that they understand coding, and especially that their staff understand coding, because often the doctor doesn't do the coding themselves. They can see they've seen a patient and it was 9 o'clock at night in casualty, there's a certain code. And the staff need to capture that and then submit it to the funder. So there are situations where some of the young doctors especially have had outside agencies to do the coding for them, and there was upcoding. We found that. So we've advised them they have to make sure in their individual practice they're responsible to understand that their coding is done correctly by their staff. We've given, when we have our annual congress, and also smaller congresses where we have weekend meetings, we've tried to put coding and coding issues as a topic for discussion, and also an opportunity to have like a workshop where people could ask questions if they didn't understand it, to try and mitigate against this. I think recently, in the last, I would say 3-4 years, the funding industry has had better IT assessments of what happens in practices. They've improved their evaluation, and I think that's why there's been such a focus on coding, and also why these outlier sort of, can I call it, behaviors have been picked up better than ever before. I think previously the IT systems just weren't able to detect these individual cases as much as it does now. The difficulty is that we as a physician association don't always have insight into how these IT systems, as you said, it may be a person sitting with a computer interpreting what happens in a practice without really understanding the circumstances of that practice. So we hope that in the future, especially after this investigation, there would be better cooperation on that side. Because the whole idea is to try and really, we cannot afford fraud. We cannot afford to have people that abuse the system. I don't care where they work or who they work with. And it's important for us to make sure that the practice must be beyond reproach, because I think that protects our patients best. Sometimes we've also picked up issues with the auditors, because some of these are auditors that do the investigations, or that develop the programs that then evaluate what happens in a particular situation. And we've often asked that there should be a South African, can I call it, development to assess the South African situation. We can't use a Johns Hopkins model in South Africa. We need to have a South African assessment. You know, if you look at some of the hospitals in America, a hospital will have 3,000 doctors. You know, we have like 3,500 specialists across the country. So it is important that we have a South African evaluation of what happens in our circumstance, understanding the demographics, and also the challenges with just the numbers of patients that doctors have to see, physicians specifically, and the volume of work that we have. To give you an idea, my practice since April, I've had a full book till December, because you simply cannot see more people in a day, and you try to accommodate, but it's not always easy to do that. So it is really important that that's understood as well, that there's a huge pressure on time and effort to be able to manage these patients. We also have had...
Before you go on, can I just pause you? And I'm going to take you back to your data when you're finished, I think. But just to ask you about your critique of using the Johns Hopkins model, could you explain to us two things? One, which schemes use that, and what part of their FWA detection system uses it? And then just take us slowly through your concerns about using this in a South African context, if you would.
I think it's developed in a very different context to South Africa. And I think if you take an outside measurement and you impose it on a different system...
Perhaps start with who is using it.
Okay, so the only people I know that's using it that I know of specifically is Discovery Health. And it's difficult I can't give you the detail. I mean, I've just looked at what they come up with results and how we've helped them to refine it over time as they understood better what our concerns were. And again, from where we started to really have discussions and interact with them to better understand what happens and how to evaluate the South African doctors and the physicians specifically that consult in the specialist fields that I've mentioned. And they couldn't, for example, pick up a person with a 180 practice number that is doing nephrology or gastroenterology that have a focus on that rather than just general physician work. In some instances, physicians do a lot of intensive care work. That again depends on where you work and where your support team sits. If you have a physician in your unit that's an intensivist, they would see more of the ICU work, for example. In my hospital, we do all the ICU work. In KZN, for example, the anaesthetist would see most of the ICU work. So if you compare a physician in KZN to a physician in Gauteng, for example, it would appear different. So you need to understand the complexities of our situation to be able to understand what the data shows. At the same time, some of the outliers have been rank outliers, and those people have really been fraudulent. There's no question about it. I can tell you that the one med scheme investigation on one doctor was to the amount of 2.5 million that I was involved with, and he asked us to assist with his investigation, and there was no question that this doctor had abused coding for procedures that weren't actually done. No question about it. He couldn't defend it, he couldn't show us the data, he couldn't confirm. You've got to say, for example, I say I've interpreted an ECG. I've got to have the ECG in the file. If I don't have the ECG in the file, I didn't do it. If I say I've done an echocardiogram, I need to actually know that I can do an echocardiogram. So the one doctor, for example, that was investigated on that side.
Sorry, Dr. Cock, would you make that determination based on assessment of their clinical notes?
Yes, so these were, again, the scheme had asked us, they had picked up this particular doctor, and they asked us just to look at their interpretation of the data, did we agree with it? Looking through it, and then asking the doctor to be able to supply us with their interpretation of what they had done. They couldn't do that. And, you know, on one scheme, 2.5 million is a huge amount. So there was no question, and again, it was a situation where this doctor was working in a smaller community, and there was no support around to evaluate what was happening. So there's no checks and balances. And that's part of the problem, that oftentimes people are in areas where they don't have anybody not looking over their shoulder, but just having a team to be able to say, look, we hope that with our annual meetings, we get people to come to the meeting, have an opportunity to discuss these issues, and again, have a collegiate approach to what we're doing as doctors.
And would the sharing of clinical notes be a violation of your code of ethics?
I don't think so, because again, when the doctor has become a member of the association, they've agreed that they would like to be part of a group that can evaluate and give support to one another. So it's part of our association's ethical rules that I would like to know that I can submit my practice to scrutiny, if I can put it that way. This has become important because over time, as you look at how private practice and the funding industry developed, there was no checks and balances in place. So, you know, if you're in your practice, you just carried on regardless. And maybe the first time somebody would ask a question is if you have a person taking you to the HPCSA, for example. So there's never been a system, like if you have a public sector hospital, you have a head of unit, you've got the registrars, you've got the junior staff, you've got a team of people that monitor one another automatically. In private practice, as a physician, that's it, you're it. You decide what you need to do, you need to decide the investigations, and we've tried to put almost like a guideline for people to practice so that a young doctor coming into practice understand what they need to do. How do you monitor yourself? I could do a stress test on every single patient. but it's not correct. But who decides that? Actually, I do. And unless I'm picked up now by a funder as an outlier, I could have stress ECGs till it comes out my ears. That's the problem. We've had to try and almost, the horse is bolted in a way, and we've had to try and put that horse back in the stable. Now, again, the majority, 99%, if you look at the numbers of people, actually do practice within the ethical guidelines. It's the 1% that unfortunately sullies our profession. And that is where we have to try and mitigate against that. Because if you look at the volume and how quickly a person can cause harm from a financial point of view, it's a lot. And that's what we've tried to actually just try and maintain not that you can police it at all, you can't. We're absolutely dependent on the funders giving us details. If they pick up an issue, can we discuss it with that person? And it could be something really innocent, or it could be a real willful abuse of the system. There's no question that there are two sides to it. And that I can say from a physician side, we've not picked up a racial, that there's one race that is more than the other. Maybe because our physician group is more spread.
If I could just follow up with this question from my colleague. So I suppose there would be two instances. So there would be one where your own peer or your colleague says, give me your clinical notes, and what they will do with those, I mean, they could support you, tell you where you went wrong, and so that they can put you back on track. So that's the more supportive function, which is what you are talking about. But there is another where a scheme is investigating you in order to decide whether you've committed misconduct that will justify them putting you on direct payment.
Yes.
So if you are now dealing with the second category, would you agree that the sharing of the clinical notes in the second context would infringe the National Health Act, because it has a provision that says a doctor must maintain patient-doctor confidentiality?
Yes. So what, for example, Discovery has done, they would have a patient, a Dr. A, Dr. B, Dr. C. So we don't have the detail of who the doctor is. They just show us the profile. And then we would say, yes, we agree or don't agree. And then if we agree that there is it looks like it's not in keeping with the standard, then they would then approach that doctor and see. And it's only been a few times where we've actually physically spoken to the doctor at the doctor's request, not at the fund's request, because, again, trying to maintain that doctor's privacy. So, and I must say, this is, again, difficult because some funders have gone ahead without consulting us at all. So I must say that this is limited to, again, as I say, mainly Discovery has developed this, can I call it a support system with the association to try and ensure that it would rather be a positive support of the doctor rather than a sanction, to try and avoid the sanction. Whereas in some circumstances, I know that from a physician side, as far as I know, not any of the physicians have had their payment stopped. I know it's happened in other groups, and that would be, again, discussed by the other groups that will present, specifically Healthman. So as far as I know, nobody in the physician space has had their payment suspended. Some doctors have definitely had direct payment imposed. And again, in some circumstances, and the one that I've got on here is a Dr. J.R. He's an elderly doctor. He'd been in practice more than 30 years, and they suddenly said to him, but he can't do echoes. And he had to then present them with what he had done as a physician specializing in echocardiography. So he's not a cardiologist. So they said he couldn't do it because he's not a cardiologist. And again, it just shows he's had the courses, he's done it, he's worked at Oxford. Again, we could assist him because we could send all of these details through, and it was accepted by the fund. So this individual type of case, I didn't have 20 million of them. I mean, it's just to show you some of the issues that have come across that we could defend a person. He happens to be white.
To ask your question on Dr. JR, it obviously goes to illustrating your point that the scheme systems hadn't evolved at that stage to distinguish between a 180 practice number performing, let's say, a form of specialist service and being legitimately able to perform that specialist
That's right.
So now has it was Discovery in this case, has Discovery changed its system to now allow for this subtlety to be...
This was not Discovery.
This wasn't Discovery?
Yeah, sorry.
Okay.
Yeah, this was not Discovery. So there's sometimes where it seems as if there's a, can I call it a mining of a code, where a code is then thought, okay, let's look at this code and see if it's abused. And then there's a series of investigations. So we've had to really try and just inform the particular funder when we've become aware of it. So this doctor did approach us, which is why we could defend his situation. I can't remember which fund this was. It was MedScheme. His payment was stopped until this investigation was completed, which of course can sink your practice.
And just to ask the question then in relation to Discovery, post your engagement with them around the subtlety of some code PCNS numbers 180 being able to perform other types of services, has the system changed?
Yes, so from my point of view, so as far as we know, so just looking at some of the referrals that we've had or people that have come to us for help, it's definitely been, it's improved. I can't say it's ever perfect, we keep working at it. And we've just encouraged them that if there's an issue, and especially if a doctor has not been open to discuss with them, to discuss with us and see if we can at least reach that person, see if we can help them through the process rather than wait until there's a sanction. Rather than be proactive than wait until a problem occurs and then try and sort of dial back.
Thanks. You said that Discovery has developed a relationship with the association to try to assist. Have any of the other administrators or schemes done that? So
MedScheme and GEMS have to a degree. MedScheme, for example, has asked us to help with assessing their guiding principles for different disease categories, and we've helped them to develop those to understand admissions to hospital. There have been times where they have had opportunities to discuss with us. For example, they wanted to impose a limitation of days on certain admission diagnoses, like, for example, pneumonia. And we've had an opportunity to give feedback to them and say, we cannot have a one-day admission. You've got to have at least 2 days to get the cultures back, for example. And they've been willing to discuss with us. Their data and practice evaluations, we've not seen any major feedback from them at all. The one case at MedScheme was a fraud investigation where they brought us the detail. The doctor had asked for our support, and this was the 2.5 million that I spoke about. There was one other doctor that was also an abuse situation, and the doctor agreed that they had wrongly used codes, and there was use of codes that were not appropriate for the physician to use. For example, ultrasound investigations that was actually done by the hospital radiology department, not by the doctor, that the doctor had coded for. There was some, for example, in intensive care where there was some double coding where the doctor didn't understand the descriptor of the code and then had the wrong code. But those were very easily resolved, and these were often, we found new doctors in private practice that simply didn't know the correct coding. And this was, again, across the board. It wasn't a specific, I know this is more on the racial issue, but it wasn't a specific racial group that was affected. And interesting enough, more men, because there are just more men that are physicians than females. So there's definitely a discrepancy, male-female distribution.
I do want you to take us back to your slides, because we started asking you questions and that took you away from your...
Sure. How do you code correctly? Make sure that your staff understand it. And there's also updates for staff to understand, again, how coding works, how to apply the correct ICD-10 codes, for example. So, again, the disease description has to match the procedure. So those have also been a learning process as people have become better. But we absolutely dependent on the funders for the data. The difficulty in South Africa, and this is again coming back to the Johns Hopkins question.
So just help me with something. The funds have given us submissions in writing. And
Yes.
BHF and HFA have told us there's no way we can know who's being investigated because nobody keeps racial data as such. No one knows because everyone follows a practice number.
Yes.
But you have been able to tell us without any difficulty what the racial breakdown is of those doctors that are investigated.
Yes.
So how easy or difficult is it for the funders to know what the racial profiling is of the doctors they are investigating?
They should be able to do it. I can't understand that they say they can't, because they do have your name attached to the practice number, and they do have your geographic location. So I must say I don't think that that's an argument that they can use. I can't see that. What I was saying about the, I was just thinking now I forgot my train of thought, about the Johns Hopkins. If you look at the physician space, again, to try and apply the data in the South African context, when you have, for example, a Cleveland Clinic, that is like a city. You hear of Cleveland Clinic, it's multiple disciplines in one area, and loads of doctors. So, for example, if you then have a person who falls outside the norm, or they don't practice according to the ethical standard that you want, you get rid of them, and the next guy comes. And in South Africa, we don't have that ability because we simply don't have people to replace a person that's not, if I can call it, behaving in an ethical way. We also have evaluations where we try to ensure, I'm on the Netcare ethics committee, for example, and the clinical practice committee. So if we pick up an issue with a physician specifically, that case is then discussed with the doctor present with the Netcare management group to see if there is a situation where we can support the doctor. So it may be an older doctor that's not practicing according to their ability anymore, or a doctor where there's clear questions about their clinical expertise. So we try to ensure that we're part of that decision making and trying to evaluate really what the approach should be to try and ensure that that situation is resolved. Because at the end of that, doctor is a patient, and we've got to make sure that the patients are safe. What I was trying to think of about the Johns Hopkins model, if you look at the Americans, they've got the American Medical Association, they have the American College of Physicians, they have an entire board just employed by the American College of Physicians doing this kind of support system for their doctors. We have to practice. This morning I started my ward round at 5 to be in time here. You do it whilst you're practicing medicine. My whole exco are all practicing physicians. None of us are only doing the association. And that's part of the problem, that oftentimes we've had to try and fit in, to try and have these meetings with funders. It's often after hours, to try and ensure that we have a system in place to protect our doctors at the same time as protecting the patients and the health system in general. And I think that is again where these, can I call it, profiling mechanisms may not be able to really accommodate that kind of distinction, and to be able to really understand the South African context of what we deal with.
Isn't the HPCSA supposed to be performing that function, those board functions? I mean, there are disciplinary boards within the HPCSA. So is that not the role that you are talking about? Is it not appropriate for the HPCSA? In fact, not appropriate. Is it not, in fact, their statutory obligation to do so?
Yeah, I think it would be. I think there's only, as far as I know, 2 clinical people on the HPCSA. I don't know if that's changed. And again, to really understand practice, you've got to have people that are living in that space to understand what the doctors are dealing with. I always laugh when I go to overseas conferences, then you hear the guys talking, they're so busy, they've got 4 patients in hospital. If I have 4 patients in hospital, I'm stressing because, where's all my patients gone to? So it's the volume of people that physicians have to deal with. There's no understanding of the hours that physicians work. And sometimes even the pressure, because as I said, the buck stops with you. There's no more senior person than the physician to make a decision on a patient. And there's a lot of that pressure that's not really understood. And I don't care what racial group you are. This affects absolutely everybody. And in some circumstances, people are in situations where they don't have, for example, a neurologist that they can consult, or a nephrologist, or a cardiologist. They have to do all of it. And it puts immense pressure on that doctor. He can't just refer to the next place. Where do you go to? So like Kimberley goes to Bloemfontein. That's 2 hours away. Uppington has to go to Kimberley to go to Bloemfontein. You know what I mean? That again, that context of where the person is working absolutely influences what. So oftentimes they would rather admit the patient where they can physically observe them and monitor them, rather than take a chance in sending the patient home. So I think it's always, it is an HPCSA function, but I think the clinical context is sometimes not available to the HPCSA. And again, the processes at HPCSA has been quite slow to actually anticipate these changes. I mean, telemedicine, for example, there's no rules in South Africa to govern telemedicine. Yet my patients send me WhatsApps. They send me their sugar profiles on email. I don't charge for that time because there's no code to describe it, but I spend time with my patients, respond to them. But that, according to HPCSA rules, actually is not allowed. They want you to have a face-to-face with a patient, and that's simply not always possible. So it is a difficult one. There's no, I think the HPCSA, the clinical aspect, again, is not always sort of borne in mind.
If I understand you, we have a coding system that is not in tune with the clinical context of South Africa.
Yeah.
But the clinical context itself takes into account the social disparities of South Africa.
Yeah.
We just do not have enough doctors.
Yeah.
And we have a lot of poverty in South Africa.
But it's not just poverty, it's the burden of disease. I mean, if you look at the chronic diseases, the non-communicable diseases explosion in South Africa, it is just scary. I mean, I was at the Department of Health the other day discussing the NCDs and how do we manage the burden of what we face. And, in the past, for example, it was said that black patients don't get heart disease. So I've recently had at least 5 young black men die of cardiac infarct. So we have to change our thinking. And again, we again, the same group that do these evaluations, that practice, we're also the people doing research. And sometimes we can't actually report back on what we see because we simply don't have time to do so. But it's this kind of, so we're trying to also with the guys in the academic world to try and bring these issues in a physician space to the fore, because there's a changing dynamic on that side. HIV used to be #1 killer. That's #5 now. Cardiovascular disease is #1, diabetes is #2. And yet in some provinces, for example, in many provinces in the public sector, there's no glucometers at the clinics. And we try to help the academic sector from private practice to try and ensure that we have a standard of care to prevent complications in the future. Now, this has nothing to do with racial profiling. It's just the burden of disease in our country. And to understand if there's a change in how these diseases occur, where can we interact? I mean, why are we doing so well with HIV? because, first of all, the drugs became more affordable. Secondly, we've understood that there was a problem. Thirdly, we had a better approach. There was a standard across the country. Everybody does the same thing. And whether you're in public or private, you've got a standard of care. And that's why we could get on top of it. The same thing is possible for the other diseases as well. And the physicians are the people that need to drive this.
You say the burden of disease doesn't have anything to do with race, but would it not be correct to say that the burden of disease would be related to socioeconomic status?
No, I wouldn't. We really see these non-communicable diseases across groups. Interesting enough, the NHCPA data from 2012, the South African NHCPA data, there were 30% of our Indian population are diabetic, 30%. 12% of our coloured population, 8% of black and white are diabetic. And of the black population, interesting enough, at that evaluation, the urban blacks actually had a lower diabetic risk. So it doesn't hold, sometimes we have a feeling it should be. That showed it didn't. So again, and that was across the demographic groups. It wasn't, and socioeconomic groups. So we see a spectrum of disease in everybody. I mean, this is one of our gripes with the medical aids, is that they have plan types. I've got a standard of care. Now the patient comes with, say, diabetes, for example. If you are on this big executive plan and you can have a big basket of care, you can get this. Now you are on the lower plan, you can get this. The problem being, the patient that I see have diabetes. I don't know what plan they're on. They may belong to medical aid A. So I have to treat them according to the standard of care of treatment for diabetes. I don't know what plan type the patient's on. And that's often where our problems come from, is to try and ensure that that patient gets a fair management of their disease. And I understand that there are limitations to what can be afforded. But again, you're preventing complications in the long run. So that's part of our other work as physicians, where we try and interact on how these protocols and treatment algorithms are developed, and to ensure that the patients often in the lower plans are often the sickest patients. Doesn't mean that the guys on the higher